A very good evening to all. This is Sinia, along with Sangeeta and Sharath from the Forum. Thank you all for joining the last and the fifth session of Virtual Volunteer Training Program. Today we are going to discuss on the last but the most important topic, that is community and palliative care. We do have our faculty and facilitator join here with Mr. Sharath K is our faculty for today's session and Radha ma'am our facilitator. For further faculty introduction and session facilitation, I invite Radha ma'am. Over to you, ma'am.
Welcome to all. As Sini has already said, time has gone past so quickly. It was like Monday, now we are in Friday. Okay, we have had 5 sessions, all important ones for volunteer to be aware and happily and confidently to at least be part of a team, and you will keep on growing. See, you're not going to learn everything. By the end of this session, I'll tell you something which will be a good tool for learning. Okay. So today we have got Mr. Sharath K, who is a very active, energetic person. A personality of that kind is needed to be in the social welfare team. Okay. So he is one of the organizational affiliation coordinator for community engagement department in Parliament, India, Trivandrum. Excuse me, he has completed his MSW from MES College with specialization in community development. So that is the essence, what is needed to be part of community and also to get the maximum out of the community also. Presently, he is in charge of the Community Engagement Department in Parliament, India, and he's been associated with Palliative for the last couple of years. And his main areas of interest are community-based home care and pediatric palliative care. In both, he is actively involved. Over to you, Sharath, to take us through the session today.
Thank you, Radha ma'am. Actually, it's very good to see you after a long time. I think you've been there for my previous session when I was taking a session for, like, I think it's another volunteer training or FCPC session. So thank you so much, ma'am. So without ado, hi everyone. So I'm Sharath, and today's session is something that you're gonna relate to yourself. Is what we are going to do in the community also. So that's how palliative care works. And without further intro, I'll get into my session. This will be more discussive session, like it that way. And your contributions will be most welcome. And if you have any doubt or something, just put it in the chat box or just raise your hand and just ask me. If I'm able to reply to your question, I'll be okay with that. And if I have any concerns or doubts or anything, I'll just refer it with someone else and I'll guide you through. Okay. So your questions will be answered, that's for sure. So let's get into community-based palliative care. So starting with the simple question, what is palliative care? So anyone can answer simply. What is palliative? I don't want to go with like the WHO's definition and all. We have gone through that in the previous sessions and all. So what is palliative care? What is the meaning?
Hello.
Yes.
Hello, sir. Good evening, sir.
Yeah, good evening.
Palliative care is who are suffering with the critical ill disease. We are providing the quality of care and extend their life.
Yes.
So it is called palliative care, sir.
Okay. So what I heard is extending their lives. So we'll just get to that point. Okay. So the primary focus will be, as you said, improve the quality of life of the patient. So that's what we do. That's what we really mean about palliative care. So what is the purpose of palliative care in community? Can anyone say?
To provide supportive care and basically it is to extend the quality I feel quality of life, improve the quality of life.
Thank you, Reena, for that wonderful explanation. So this is what palliative care in community means too. So that's what we are going to discuss about, and how a volunteer or how a person who is opening to just contribute to the community and contribute to palliative care. So that's what we are going to discuss, and so we'll be going through our sessions. So in the very start, so I'll be just giving you a small picture. So can you say what is this? It's a tip of an iceberg. So as it's mentioned there, so you can know that it's a tip of an iceberg. So I'll just go through a small incident that happened. Then we'll discuss about the actual thing. Okay. Now, when you see a problem from the outer side, everything is very simple, because we can't we will be a person who will consider everyone's problem as much as simple as possible. When it occurs to you or your beloved ones, then it will affect you, and then it will be a much bigger crisis in your life. So that's how this works. When you see a patient in the community, when a patient comes to a palliative care clinic or in any other setting, so what you see in that person is just the tip of the iceberg, because the actual problem lies underneath that, like this. In the previous one, we have only seen a patient's small problems. But when you go very deeply, or when you get to know about that person, the underlying problems are so much that we will be more worried about. So when you consider one patient who's having physical illness, pain, and discomfort, the underlying problems will be starts with declining faith and hope. Then there will be problems with economical crisis. There will be trauma, abuse, violence, or concern about family issues. Then there will be fear of death. And in some cases, there will be social rejection too, due to their illness. We always categorize the patients as this patient is having cancer, this patient is having AIDS, or some other weaknesses. This kid is having mental disability or mental retardation. So you just consider them as only patients. We don't consider them as individuals or humans with having so much illness or some conditions. So there will be a social rejection too. Then we consider other parts, like the sense of worthlessness that comes in that person too. Then the loss of job, and the fatigue that comes for the caregiver who's taking care of them for uh, almost a year, couple of years, 12 years, 20 years, or something. So they will have their own problems related to their caregiving time. Then the declining mental health of the patient and the caregiver, then the rejection by the medical profession. So there will be like problems like doctors will be telling nothing can be done medically, so a miracle could happen, or you can just go to palliative care only. So that's the end. So then suicidal ideations will be there, then sexuality issues, then fear of worsening pain or other symptoms. So these are the things that is underlying in a patient. When you consider that person, or when you see a person at first, you won't know. You don't get to know that that person is having so much issues. So in palliative care, this matters. This really matters. Because we are not only focusing on the physical pain of the patient, we are focusing on the physical, socio-economical, psychological, and spiritual realms too. We are touching all the facts and all the things. So that's what we do in palliative care in Pallium India. So that's what we educate to everyone. Not only consider the patient in their physical problems or just consider their physical pain or something. You have to consider them as a whole person. So this is the first thing I would mention. So it's I know you have gone through a lot of sessions with having these kind of illustrations and all. So I won't be jumping into and just giving more detailed things. If you want it, just ask me. Okay. Then the simplest thing, the possible social consequences. First thing will be social isolation. So socially, the person will be isolated and they'll be having no help from others. The family will be not very supportive. So that isolation is a consequence of their illness. Then the dependency. They will be dependent on someone. If that person is having some issues with their family also, they can't ask them or they can't just go and tell, okay, I need this. Can you do this? No. Before the illness, the person could be leading a healthy life and they'll be so much abusive to that person also. So they'll be having that inner problem to open up and ask them. So that dependency is also there. So they can't just go and ask them anything and they'll be relied on some persons to do their daily chores also. So then economic instability, when a patient is diagnosed with something, that will always lead to economical problems. Like financially, they will be unstable. There will be more surgeries needed. There will be more medications needed. So this makes them more vulnerable in the side of economy. So that will lead to economic instabilities. Then lack of social support. So social support is something that comes from the community. So if the person is not a socialized person, if they're not having any proper relation with others, so they won't be just coming and giving or offering any help or something. If there's no guided volunteers or any palliative care team, so the lack of social support is there in relation with the patient. Then the job loss, of course, we know that. Then interpersonal problems. When a person is diagnosed with something, that will lead to more anger, more hopelessness, and there'll be so much doubts, so much things going in the patient's mind, and that will lead to interpersonal problems with the very connected person. So they won't be able to talk with the person very freely. They'll be having so much doubts about talking, or lack of confidence will be there, and it will lead to so much problems that can only be just measured or just monitored or just helped with the help of a psychologist or with the help of a professional only. So these problems will also cause a person who's having illness. Then inadequate facilities. As we know, when we consider a patient, if that patient is having a spinal cord injury or anything that relates to his mobility problems, then he needs adequate facilities. Like if that person is not movable, then the person needs a wheelchair. If the person is having problems with his day-to-day, like when he can't use the bathroom or he couldn't go without the help of a person, then he needs commode chairs. Then if the person is having bed sores or other problems, then they need a bed with some cushions or air beds kind of things. So these are the facilities that need that to be facilitated when a patient suffers. So inadequate facilities will be there. So that will also cause some problems. So these are the possible social consequences that occurs to a patient. So as I said, as you have gone through this, like the total pain not only connected with physical realm, it connects with the whole things, like the four major parts: physical problems, psychological problems, socioeconomic problems, and spiritual problems. So in these four things are connected and they will get to the total pain. And we can get a proper view like the total pain of a patient. When a patient comes, you don't have to just look into the physical problems only or the psychological problems only. You have to consider the patient in his own state. So you can just grasp a proper knowledge about what is happening, what are the things he's going through or she's going through, and what are the things that needed to be taken care of. Then only you can just tell or just get an idea what is the total pain. Then only we can solve, we can just direct them to any other things that could relieve that pain. So this is the case of total pain. Then it's a simple sentence. You can just go through it, simply saying, not in subduing disease or prolonging life. Rather, palliative care is a form of treatment that focuses on making a patient's life more comfortable, happy, and dignified as long as they live. So that's what we do. So that is the purpose of a palliative care team. In that case, every person matters. If it is a doctor, it's a nurse, it's a social worker, it's a volunteer, if it is a psychologist, if it is a physiotherapist, everyone matters. So that's why I'm just giving you a brief idea about how a community-based palliative care needed to be directed or how it should be done, what are the components of community-based palliative care and all. So these are the basic things I'm just going through. So these things you all know about it, and so I don't want to go more elaborative. So we'll be just getting into our main topics. So first, I'll give you just a brief, like a small introduction about the palliative care movement in Kerala. So everyone from around the world is very like knowledgeable about what we do in Kerala. So first OPD started in Kozhikode. It was in 1993. Now it's 2003, and we're talking about a thing that happened 30 years ago. So the first OPD was started in Kozhikode. Then the first Link Center was started in 1996 at Manjeri. Then the community-based movement in Nilambur was happened in 97 and NNPC in 2001. NNPC means Neighborhood Network in Palliative Care. So we will talk about it briefly in the coming slides. Then the palliative care policy that was started in 2008. So that was a time where the Kerala model of palliative care started, and we initiated a palliative care policy, and the government approved it. And that was the start of palliative care in Kerala properly, from the help of government. Then government level palliative care initiative facilitated by the Arogya Kerala palliative care project. And because government also want to just participate, because they can't allow, like they are the front runners in palliative care in Kerala. So they'll implement more policies, more programs for the patients who needs care. Then we got an update in palliative care policy in 2019. So that is the latest one. So these are the things that happened in palliative care movement in Kerala. I think you have gone through all this. So I'll just, can I just move into the next slide? Okay, so I'm just moving in. So when we talk about palliative care, a pioneer of palliative care in India, it comes as like the name Dr. M.R. Rajagopal. So you're all aware of him, and he is the chairman emeritus of Pallium India right now. And he is the person who started something that is undoable in a public setting. So I'm not going very further and just giving a big speech about Rajagopal sir. So he is the one who started palliative care in Kerala, and he is recognized as a person who is very humble and who have a vision to eradicate the pain in the patient. So moving on. So what is Pallium India? So how we contribute to the society? So we just started in 2003 as a national charitable trust, and we try to alleviate health-related woes. We demonstrate, educate, and facilitate to integrate palliative care into mainstream healthcare. Because first thing, we demonstrate. We just show how it can be done. We'll educate, like we are doing right now, and then we facilitate. If you need any help, then we'll come to there. We'll have a proper sessions for you, and we'll just educate how it could be done, and we'll be giving you proper classes so that no one is left behind. Like the education that we have, or the things that we have in palliative care, or the model that we have in palliative care. So we need it to be just given to everyone, so that everyone can use it, and it will just aim to the care, or the quality, improving the quality of patients' care. So that's what we do, and we are just focusing mainly on these three things: demonstrate, educate, and facilitate. So we have four kind of services. First one will be OP, outpatient department. Second one is IP, inpatient, and then home care. So in home care, we have the vast majority of volunteers, nurses, doctors, and everyone. So it's a everyday process. So we go to home care in in the whole Trivandrum. So we are just connecting with every possible link centers here, and we do have 14 link centers as per now. A link center means a place where we provide our help, or we provide our service. Then the telemedicine. So where 24/7 anyone can call and just get proper treatment guidance through telephone and video call facilities also. And I'm not just telling you like, okay, we are doing this. No, it's just a basic idea. So what we are doing. Then the rehabilitation activities, the employment of patients, the educational assistance. So it is called Kutikotam. It's a small gathering for the children whose parents is having some illness or something. So they will be registered here. So their children will be taken in. Their education purpose will be met by Pallium India with the help of their supporters. Then we have owner. So this is a bereavement support that we do, and it is a community-based thing. Like if the patient is deceased, the caregivers or the family members, they'll be coming to a place where we meet, and we'll be having a meeting every month, and so they'll be sharing their own stories. With the help of that, we'll be just guiding them to so many things, like if they want to start a new thing, new job, or new enterprise. So we'll be guiding them how it can be done, what help can be given to them. So that kind of things done in our meetings. Then the counseling. So for the counseling part, we have psychologists here. So these are the rehabilitation activities we do in Pallium India. So this is simple thing about Pallium India, that what we do. So then we'll just go through what are the components of palliative. In this, from this, you'll get a proper idea how a volunteer or how a community is properly integrated with palliative care. So first one will be the focal point of care is the patient and family, that we know. From the previous classes also, everyone is telling you like patient, we have to treat the patient as an individual. We have to just consider them as an individual, and we have to focus on them only. And of course, their family members, the caregiver and the family members. So the focal point of care is the patient and family. Then the patient is treated as an individual. Next one will be the inpatient treatment facilities and home care are provided within the community for palliative care. Then the treatment focuses on symptom control. So that's what we focus mainly. So we can't just eradicate the whole disease. So we have to, from the start, we'll have to focus on the symptom controls. Then palliative care requires multidisciplinary collaboration. Then comes the important factor. Volunteers are an integral part. Palliative care requires multidisciplinary collaboration means we have to collaborate with so much facilities like PHCs, CHCs, like means public health centers, community health centers. And for that, we need a proper connection. This can be made out with the help of volunteers, because we can't go in there and we can have access to everything. As a volunteer, you will having proper knowledge about what is happening in that community itself. You know where to go, where to find proper channels, and you can go through that. So with the help of that, we'll be able to go further and just get a proper team, a multidisciplinary team. We can get the proper collaboration. So then palliative care is obviously community-based. Then the services are available even after the death of the patient. As I have mentioned that we have that ONAV program. It's a bereavement program. So after the death also, that family needs help, or that family needs to be taken care of. Then the services are available 24 hours a day, except emergencies and casualties. So palliative care service can be available 24 hours, but it's not an emergency or casualty care. So these services are available even after the death of the patient. So these are the components of palliative care. Then the major factors which connects to community-based palliative care. The first one will be CBPC, simply community-based palliative care. A community can link the patient to a palliative care system. A community can identify the patient. So that would be the first one. Then the patient can be linked to any proper services, palliative care services. Then a community can fulfill the needs of a patient with the resources that is being there in the community. Then the community can energize the patient with more activities and all. Just a second. So community can care for the patient. So these are the 5 things that a community-based palliative care approach needed to be taken care of. This is what it means. So when we are going through, like when we just elaborate, the components of CBPC means, first one will be community volunteers. Second one, student volunteers. Third one is a whole team, like healthcare professionals, voluntary services from doctors, nurses, psychologists, psychiatrists, social workers, and physiotherapists. So this is a graph, like on the top, there will be professionals. It's not that they are the epitome. With the help of the baseline, like basic supportive services in the community, only we can go to the professionals. So these are the components. So this is where a community-based volunteer get more involved. So it either can be a volunteer only, it can be a student volunteer, or it can be a healthcare professional. With the help of these 3 major persons, or as persons actually. So these 3 major persons can contribute more. So these are the main components. So with the help of that, we can just build on properly. So then formation of CBPC communities. The formation of community-based palliative care communities starts with the awareness creation in the community, like what we are doing right now. And when you just go to a community, so we have to create an awareness among them. Like they will be today also, when I'm saying we have a policy that was initiated in 2008, we have, and that policy has been updated in 2019. And after all these two, in here in Kerala too, we're having so much people who are not very aware of what is palliative care. Whenever some person comes for palliative care, whenever they say like, okay, I'm from palliative care, so I'm here to look for your mom and dad. Then the neighbors will be telling like okay, oh, that person is going to die. Okay, these are his last stages. So that's why the palliative care team is coming. So that kind of awareness is still lacking. So first thing, we have to start that awareness among them. So starting with awareness creation in the community is the first part. Then from that, selecting individual from that community for volunteer work. Because everyone is not really willing to work. Because they will be like some persons have their own works to do. In between, they can come and work. So we have to just categorize or who is having interest in palliative care. So we had to just focus on them only. Then after selection, volunteer training for the selected volunteers can be done, like what we are doing right now. So we can just give the awareness first, then we can select the individuals, then we can train them. Then sending the trained volunteers to their community to find out the needy. With the help of that trained volunteers, we'll get patients. We can give the help to them, those who are in need. Then we can form a group with a specific objectives. Like we can fix a team for home care. We can fix a team for advocacy. We can fix a team for awareness creation. Based on objectives, specific objectives, we can form groups. So there will be some persons to take care all these things in one group. So there will be a leader for one group. So there will be persons to like properly educate others who's joining. So we can split into small groups that have specific objectives. So this is the part where how we can form a CVPC community. Extending of this community-based palliative care depends on these volunteers. So next one I talked to you about is NNPC, that means Neighborhood Network in Palliative Care. It's very simple. The word is very long, like Neighborhood Network in Palliative Care. It's what we do in our locality is related to it's like empower the local community to take care for the patients in their area. Actually, if we are doing the work there, it's only part of NNPC. And to develop a cost-effective method for providing palliative care and to take care the helpless near their home. That's only the short answer for this NNPC. Take care the helpless near their home. If you ask the detail about a patient, the neighbors are more aware than us. So if they are aware about palliative care, if they form a network for palliative care, that will be much efficient. Means they can get the resources from their own community and they can just facilitate it. So they don't need any person to come and give palliative care treatment or something. So they can just provide it. And I'll just go with a simple example. What happened in Pallium when I was in a home care visit. I was visiting a patient who's living on top of a hill. So his house is located there, and in that house, a mother, like a 65-year-old mother was there, and a 68-year-old patient was there. So they were living alone, like a couple who's living alone, and they don't have children. Their relatives are very far away. So when we reached there, it was quite difficult to reach there actually, and they needed a small tarpaulin for because it was heavy rain there, and they don't have a proper house, and we don't have that thing with us. So when we reached there, we found that there's a need of a tarpaulin, which is a not a permanent thing. It's a temporary one, but it is very helpful for the rainy season. So when we just asked them if there is someone who will be just getting help for you, or is there someone whom we can approach right now? So they said, there is one person who will come in between, so who can help us. But we didn't ask them because he visits now and then, so we don't want to bother them. So what we do is we just visited them. We asked them, can you just connect with someone who can just help for that right now? So he said, oh, I didn't know about that because they didn't told anything about that. So he said, I'll just get help from the neighbors. I think when we left the house, the help was not given. And after we visited 3 or 4 patients, then we got a call from that person who was in the neighborhood. And he said, we collected, or we just purchased the tarpaulin, and we just going to the house, and we'll send you a picture. So it will ensure that they are safe now. So we said, thank you so much for your help, because that's what needed. Because we don't know actually who's going to help in your bad times. Neither it will be a neighbor or some other random persons. So at that time, that person just gathered some people and just asked for help. So they just raised some money, and they just bought a tarpaulin and facilitated that thing. So this is how that network works. Take care of the helpless near their home. So that's what it really pointing NNPC means. Neighborhood network in palliative care. It doesn't mean that we have to just go and just help them with economic support. No. If that patient is suffering a lot, if we are able to just go there and have just spend some time or just talk to them, that will also very help. So this is the basic idea about NNPC. And here, this is what our Palliative team does. And this is a picture of our PCEs, like palliative care executives, and the nursing team and the social work team. Everyone just go visit the home, and they're just providing that food kit and all. So this is a kind of a method. Like if that place is not very approachable, we have to just give the help to them. Like a network or trained volunteers in the community support system of trained professionals, institutions, and organizations, or palliative care institution as nodal centers. So this is what we really means by this, like the neighborhood network in palliative care means. It doesn't mean that we have to just go every day and check for them. No. If they need any help, we have to just facilitate it without just harming ourselves also. If we are able to just gather someone, we can. If we can only provide it, it's good. If it is out of our hand, then we have to just ask for help. Like, okay, this is a problem we found here. If anyone can get the support, or if anyone can provide the support, so we can just give them. So that's what we have to do. That's what that NNPC means. So this is a method also. So that's about neighborhood network in palliative care. And the next thing is compassionate community care. Simply CCC, triple C. It uses 3 core principles to create a culture of caring for fellow human beings as community. First one, compassionate means compassion. Second one, community. Then the third one is care. So you can just check it like compassion means simply all people are entitled to be treated with dignity, respect, and equality. That means we don't have to prejudice and non-judgmental. Simply, when we consider ourselves also, we want that dignity and respect in the society and that equality. We are not ill right now. We'll get more diseases in the future if we are not following healthy habits. Then we'll also get to get more diseases like this. So at that time also, we also need that dignity. So that's the case of the patient also. They want that dignity, respect, and equality. So the second one will be the community. All people have the right to information. Like we'll talk about, I want this, I have this right and all. I have the right to education and all. That's how everyone needs. Like all people have the right to information, education, and support to help them find answers, get help, and make informed decisions that respect their personal beliefs, values, and needs. In a community means a commonality will be there, so that people share some beliefs, some values, and they'll be having some commonalities. So then the next one will be the care, what we are just providing. Like all people are entitled to the care they need. A person is physical, mental, spiritual, and social. Means each of these areas needs proper care. If we are having a problem in our office, it doesn't mean that we have a physical problem. It may be a mental problem, like something related to our psychological issues. Like if we are frustrated with something that's happening in our surroundings or in our house, or related with some relationship problems. So these whole things are connected. So that's how, if these problems arise, we will behave very unnaturally. If we consider our problems also, if we are having so much problems, then if we are behaving more like this, you can just simply connect this with the patient, because that patient is not movable, or that patient is having going through a lot, and if they are behaving like that also. So all people are entitled to the care they need. So they want care, they need care, and we have to just facilitate it, and we have to just understand that also. So that's how a compassionate community care works. So first thing will be non-judgmental attitudes, prejudiced. We don't have to prejudice all these things, and we have to think that a commonality will then there with the community, and the care we need to give, because everyone needs care, and every areas needs proper care. And the next thing, here we're just entering into the proper community volunteering. The source of information in palliative care should be collected from these three methods. First one will be simply the patient or family members. Second one will be the caregiver who's taking care of that patient. And the third one will be friends, relatives, neighbors, local bodies, etc. That means NNPC, neighborhood network in palliative care. These all comes under that. So these are the source of information in palliative care. When we compare this, here comes the main part, volunteers. As I said earlier, volunteers are the integral part in community-based palliative care. So as you simply just go through it, like volunteering is a voluntary, because we're not compelling anyone to do this. It's an activity that is concerned for the welfare of others and is intended to promote good or improve the quality of human life. We don't know properly, like, okay, there is a wording I heard in my earlier classes or something, like, you can be, because you have suffered a lot, means in the past, you'll have been taking care of someone. Now also, you'll be taking care of someone. And in the future, you needed to be taken care by someone else. That's how the life works. Because we help someone, we need help in the future also. So we don't know what will happen in the future. So it should be coming from our mind, our heart, that if that person needs help, we have to do it voluntarily. We don't want to just, we don't want something back. If you do the good, you'll get the good. Karma is a boomerang. Everyone says that. So like that also, it is intended to promote good or improve the quality of human life. So volunteering means simply as that. And also in turn, this activity can lead to self-worth and esteem. We will be, when we go to sleep also, we'll think, okay, yeah, I have done this, I have to do more. Yes, that's what we feel about ourselves. And there is no financial benefit to the individual. That's the biggest part. But the volunteering can have positive benefits for the volunteer, the person served, and the community. So that's what simply volunteers means. So then the next one, role of community volunteers. We have a much more complicated role than others. A doctor, a nurse, a social worker who studies the course and they're just designated for their work. But as a volunteer, we'll get only the information from this kind of training sessions or from the community or with experience in your life. So we have to be like our work matters more properly. So that's the first thing. First, the role will be the emotional support or social support we give to the patient. Because everyone needs that care from any person. So first thing will be we have to just think of them in their position only. So the emotional support or social support is the first thing. Then after proper training, I would say after proper training, basic nursing care can be done by a volunteer. I'm not just putting it very simple like nail cutting, give a bath. No, it's not only that, it's more than that. Even the hair setting also, like combing the hair and just making them look more approachable or more beautiful, that is also part of a basic nursing care. So we have to think like what would make them or what would make the what would improve the quality of life of that patient. It may be a simple thing. So that's what comes under this basic nursing care also with the trained professionals, because if you get the training, you can do that too. Then pursue professional home care. When you are into this proper trainings and everything, you will get a proper view like how things can be done and next thing, like what to do next. And these kind of things can be get into your mind properly. So it will lead to a professional way also. So you can give a professional home care to the patient. Then the last thing will be linking with professional team. If you are not able to just properly do everything at once, you can just link that person to another one. Even if it is to a volunteer, no problem. If it is to a doctor or a social worker or a psychologist, it can be done from your part. So that's the main roles of a community volunteer. So they can just facilitate all these things. So then the social support to the family through a volunteer means we can firstly we can ensure the food. If they are getting enough food, then if the children is getting education support, then availing transportation facility. If they're having any problem with transportation facility, if there is any economic problems, then we can just check for any like simple transportation things, like you can use a person's help, or you can ask for a help from any other person who is able to do that. Then linking with local support group. Here we call it as a LSGD, local self government, like governing department. So we can also connect with them also. Then rehabilitation works like if something could help them make or earn money, if a group can help that, then we can also facilitate that. Then facilitating government schemes. In Kerala, we have so much government schemes, starting from the disability pension, old age pension, everything. So they won't be more aware about that. So we can just give them details, and we can just facilitate all these things. And if they are not able to just go and just fill in the forms, or if they are not well educated, then we can help them. These simple helps can be done from the part of a volunteer simply. It comes under social support. Then the awareness creation, of course, we can do that. Then training for family. If they are going through a rough patch, then we can just guide them to any other professional so they can give the training. And the basic nursing care that they can offer, we can also teach them. Then administrative works if something needed. Then fundraising activities like mass awareness creation, and with the help of that mass awareness creation, we can just raise some funds also that will help us to grow our palliative care team. So these are the things, these are the social support we can get with the help of a volunteer to the family. Then the community model in palliative care. So this is what we do in Kerala simply. This is that elaborated thing. So first thing will be the patient or family. So they'll be having problems in these three categories. So I didn't add the fourth one, the spiritual one, because it's a more complicated one. So we can focus after comparing all these things, like going through these three things: physical, psychological, and socioeconomic terms. So a patient is always having these three problems, maybe at least one. So then we can just connect with a volunteer group, ward member, ASHA workers, CDS or ADS or Kudumbashri members here. Through them, we can just connect them to professional voluntary team, like a doctor or physiotherapist if they're having any kind of physical problems. Then social worker or psychiatrist if they're having any psychological problems. Then a student volunteers or support group. So we can just guide them to just handle that socioeconomic problems. And after connecting them, it will come to the government palliative care clinic, where we have proper treatments and proper schemes. Everything is there in the government palliative care clinic. So we can just refer with the help of them, then to the palliative care center, then regular follow-ups. These regular follow-ups can be done by volunteers, groups, like volunteer groups or ward members or anyone that comes under the professional voluntary team also. So they can do the follow-ups, because if the things are like, if the problem is okay, or is there any more problems happening or something, we can just go through that with the help of regular follow-ups. So this is a basic community model in palliative care. So next one is simple, but it's very complicated thing, but we don't have to just go very deep. It's simply that, what is a support group? So a support group is something that needed to be started from the very smallest part, like emerging initiative. Without an initiative, nothing can be done. So emerging an initiative is the first thing. Then only we can just go through the process and just get to that last phase, patient care. Then after emerging the initiative, we can go to search for volunteers through calls, conversations, so we can just gather information about them. So how we can just make use of them, how they can contribute. So what are the positives, or what are the things they can do, they can contribute. These kind of things can be searched. Then with the help of them, we just go to search for organizations like clubs, art, sports, youth, cultural clubs, then residents associations, NGOs, religious institution, schools, colleges, students, neighborhood, ward member, ASHA members, CDCs or ward councillor. So after that initiative, searching for volunteers will make them, and they will just guide or they will just go through all this. They are the connecting points. They'll just search for these kind of things. With the help of that, we can just help for the patient. So after just searching that thing, then we'll have a meeting, proper meetings with them. And then connecting with that thing, then we'll just go to panchayat or municipality. We can't go straight to the panchayat and municipality. We have to form a committee, or like we have to conduct a meeting, and we have to set some things. Then we can go to panchayat or municipality. Then we can form a committee with the help of panchayat and municipality. Then we can just give, with the help of that committee, we can provide palliative care awareness, training, and workshops. After these workshops, training, and awareness campaigns, we can just conduct fundraising events. Then these all things lead to patient care. This is called a supportive care. Starts from an initiative and it ends to patient care. So that is how a supportive group works. So this is the picture. Here you can see the students from very near college, like VHSC, Vocational High Secondary School, Virinyam. So they are donated 2 airbags to us, like Palliative India, as part of their SAPC NSS activities. SAPC means Students Initiative in Palliative Care. NSS means National Service Scheme. So as part of their curriculum and their work, they provided 2 airbags to us, and they mobilized fund from collecting newspapers and sell it to near scrap shop. Then they give it to the school authorities, and from them they take these 2 airbags and they donated it to us, Palliative India. And after that, it just went to, or we just provided it to the needy patients. So this is how the whole thing works. As part of a support group, that initiative should be taken from our part. It can be taken from the student's part. Then after all these things, and when it comes to the palliative care awareness training and workshop, then we can know about, or we can just conduct that fundraising events. Then we can provide it to the patient care. So this is how a support group works. So this is the biggest example of their contribution. So this is how that proper thing works, that support group works. So this is a simple quote, simply like it's saying, when I is replaced by we, even illness becomes wellness. So if a person is suffering from an illness, we can make the thing into a wellness with our participation. So do you have any doubts about this, like the support group or community model in palliative care? I know it's a very deep things to focus on. So that's why I'm just asking.
They've all been asking, Sharath, I'm all through the session, I've been thinking really so good, well explained, because everyone, so many, there are like some software engineers and different people in this group who have all been asking, what, so many things is impossible, cannot be done. So you have given with example. So really big thank you to you as always. And I would like to say something about Sharath. Always he is happy, cheerful. Okay. If you do something happily, whatever effort you do will be quadrupled. That means Your effort, if it is 25%, and if you do happily, it will become 100%. Okay. So that was told to me by my parents. Okay. And you have explained so well. They like normally, can we come out of the screen, Sangeet, please?
Yes, ma'am.
So that we can get to see all of them. And because they have been really asking every day, we go past the time, Sharath. So let them ask you, and then whatever queries all of you are having, please go ahead and ask. Like normally, I'm just seeing whether, wait, let me check the participants and see whether everyone is there. Aravindan is there. Aravindan, anything you want to ask, please ask. And Prakash is there. Yes, Prakash Matthew is there. And also a doctor from, not Srinivasalu. There used to be another doctor who used to ask questions. All of you, like, see, utilize. You've got someone sitting there, clarify, he will clarify all your questions because he's actively involved. And I said, he's happy to help. He's always there everywhere. So utilize everything. Some things knocks your door once. You have to be awake, alert, smart, and utilize. Then it's your take.
Thank you so much, ma'am. I have one question for
Yes.
sir. Actually, you were mentioning in the flow of support group formation, right? The government, panchayat, municipality is getting involved. So, is it possible directly once a meeting, once a group is formed, they can themselves do fundraising from their own individual groups and then directly start a palliative care? Or is it mandatory to have a panchayat or municipality approval to do a palliative care?
Of course, we need approval from panchayat or municipality for starting a palliative care unit. So that's a basic thing. Like it can be done very there is no much complication for starting a palliative. So that will be the first thing to do. So we have to just form a committee and we have to just tell them. So these are things we are going to provide. It's not like we are going to start the works of a doctor. We are not starting with a doctor or we are not starting with a nurse. So we're just starting home cares. So where we are just going and seeing them, or if they need any help, so we'll be just providing help or connecting them with any other facilities. So that will be the first thing we can do. So for that, I think the basic thing will be getting a intimation from the panchayat and registering a palliative care unit. So that's possible.
See, in the best interest, so that nothing, see, there is no 100% guarantee that one person may crop up and say something and cause like which can be running smoothly. You don't want to burn your finger. I've been telling this from day one. Okay. If anyone is willing to take chances and be hurt and do all that, we don't want anyone to do that. Okay. Because you start and then see, because this is all for safety. Will you drive when a red light is on? Okay. If anyone is happy to drive when a red light is on, this is red light drive. If you don't drive, why? Anyone can answer.
Understood. Got it.
Anyone put up your hand who will drive when a red light is on?
That's down.
Okay. So why don't do? They are basic rules. Okay.
Okay.
Nyaya dharma. Why do you follow all that? So that no one will point your finger and say you did something wrong. This is just to save your skin in the best interest of that patient. Okay. I'm going one more step ahead. Okay, even you are okay to take any nonsense. Why on earth that patient should go through anything? Always follow rules. It is difficult, not easy. But if you follow records and rules, no one can point a finger and tell you did something wrong. So it might take maybe one more extra week, some two times walk to that government office to get it signed. See, for that matter, if you see Dr. M.R. Rajagopal, how much struggle he has had to get approval, get everything done. He might have done 100 walks to so many government offices. Perseverance is what pays finally, okay, in good interest. Not that we are not scaring you and putting you off. Pallium will help. Is that right, Sharath? You will guide them on
Yes,
all
of
these
course.
things.
Of course, we have that.
Exactly. See, there is
Sincere.
someone to hold your hand and take you. Use that.
Yeah, can I?
Okay, somebody wanted to. You go ahead, and somebody else wanted to ask.
Reena,
Yeah,
ma'am.
I wanted to ask it. I think Prakash Matthew was asking a question pertaining to palliative care unit, right? But I am asking, does the same rule apply to home care, palliative home care?
If we are going to provide home care also, we have to just give intimation to get.
The health.
Yes, of course, we have to get it.
Panchayat. Like
Panchayat,
Okay,
that-
Panchayat.
So that is the
okay.
primary
Just to
thing
say.
here. In your place, I think there is also
The
local
municipality, yes.
So we have to get direction, or we have to get we have to notify them, and we have to register with them. Then only we can do that. I'll tell you a simple incident that happened. We have these experience, like we started from 2003, and now it's like 20 years, and we have a place, a link center, where we were providing home care for patients, and there was a doctor, and we were registered, and we are doing some procedures in one person's home. So it's like it's a basic thing to do, and we went there. Means the team went there, and the doctor was just doing that procedures at that time. So there was a complicancy. So complicancy means it can be reduced or it can be treated. It's like proper, like with the help of that doctor only, so he can manage it. But what happened is, so there was problems with that patient and the family members, and they suddenly provocated and hit the doctor, and the whole neighbors came, and it was like chaos. And the doctor was showing them ID cards, everything, and like, we are doctor, like I'm a doctor, these are the team, okay, so we are going to perform some things to help the patient, okay, this is a simple thing, you don't have to worry. No one was listening, and then the police came, and after that they have to tell them the exact things. Then the police said, you can perform your things, okay, after that we will just take care of everything. Then the doctor performed, like the doctor went in there and given some medicines and all. And so it was related with a fits. Okay. So during a procedure, so fits came in,
Epilepsy.
and they thought like, okay, so the doctor is coming from some other part and he's doing something else. So that was actually the problem with that patient's interpersonal problems with the family. It's okay. Yeah. So at
More
that
of
time, if they doesn't have the authority to do, or they're not given permission from the panchayat or from the medical board or something, then that scene will be different, because they will be gone straight to the jail or just taken to the police station, and they'll be treated like we usually see in WhatsApp and everything, like doctors found he's a fake doctor, a team found like they're doing burglary or something. So they will divert that scene, with proper registration and everything. We are able to tell everyone like, okay, we are from this, and we can perform all these things. We are trained persons. So I would say, with when you start something, before that you have to just go through all these things, and you have to register, so that no complications should come in patient care.
Okay.
and for your care
Thank
also.
you, Sharath.
Thank you,
Sharath.
Sharath.
My explanation, even though was blunt, you
No,
gave a better explanation.
No,
Yeah,
I
Because-
had sorry, madam, to interrupt you. Actually, I had this query because I am doing something similar in a very small way with the doctors who had taken care of my husband. So we take care of the doctors do the regular visitation, and I follow up and I okay, I follow up and I give the feedback to the doctors regarding the patient. But then no procedures are done. They are still the doctors are treating them in hand with the oncologist of say pertaining to that patient only. But we are providing them, for
You are
example, some helping them like saline or nutrition or like sometimes stoma bags are there attached, so we provide them bags, we do the stoma care, and such procedures are done. So even that requires permission from the municipality. I still
No, we like Pallium has people like Mr. Nair and all does like that, isn't it, Sharath?
what ma'am? Can I just?
Like, see, even Pallium has volunteers for all your like what this home care areas, this Baradanur, Palod, and all they
yes,
have.
we have.
So you say about one Mr. Nair, I have not yet seen him.
That is nice.
So that is her query.
Yeah.
So what
Because
should
RT feeding, certain things where we need to educate even the family.
Yes.
So these things, these small things, we are in like say in collaboration with the doctors and the oncologist that the patient team we are providing. So I just want to know, do I mean such things also need registration? Because we are not doing any procedures, the regular monitoring of the patient, like the vitals, sometimes supportive care, monitoring the vitals,
like
or feeding, the stoma care and all these. Even suppose when there are bed sores, pressure sores or something, dressing, and all these things.
rotation.
Some physiotherapy required, all that movement, the basic you can say bedside moments and all that we are providing. So such things also require registration.
That's why I'm asking Sharath only to answer that for you.
So I'll just tell you, until or unless a problem comes, it's okay. If a problem comes, then everything will be on that team's head.
Topsy-turvy.
Like we can't say that. I can't say that you're doing. I will definitely say it's a beautiful thing you're doing. What you're doing right now, it's superb. And when I hear, without knowing you, if I hear a news like this team is going and this thing happened, then I'll be like, why such people are doing that? Because we have so much things to like. We have training team and we have that registration procedures and all. So why they done that? So without knowing that, I could have said that. But if I know you, then I will say, no, they're doing a better thing. So this is actually palliative care. So I would suggest it's good to do that, but with proper guidance or proper intimations. That would be good for everyone.
Yeah, to sum it up, I'm Dr. Kishore, a psychiatrist. Can I put this word like
yes,
go ahead.
Legal versus moral?
Yes.
So we need to be more. We need to follow the legal thing.
Yes.
The soup, sometimes, as you rightly said.
Yes.
So we need to be
Safety,
careful.
like to save ourselves and save our patients, to protect ourselves and protect our patients. And end of the day, everyone, for all the hard work anyone does, why on earth someone should feel bad? You're not entitled for that. You don't deserve that.
Thank you, ma'am. I got
because if you are doing that and when you get experience, like a bitter experience, then you will be when
You'll
someone
stop.
comes to you, yeah, of course. When someone reaches for help, also you will tell, no, I'm not doing this right now because I have experienced something. Okay, I can't do that. So for that, I would say go through proper things. So you will be like, you'll have that self-esteem. You're like,
Got it. Got it.
and ma'am, what's your children's name? Kid's name? Her name? So who's
Oh.
there now?
Oh, that
Sharath,
is my
actually,
niece.
Niece,
That is
okay.
my niece. I don't have kids. That's my niece. She's come to
Okay.
visit.
No,
Okay. Okay.
she's actually she's a carer. She lost her husband recently, so she's doing so much from. She's really God be with her.
Yes, God is there and we are all there.
Thank
Okay.
you.
Thank you, Sharath.
Thank you so
That
much,
is,
Sharath.
Yeah.
Thank you.
That is Sharath. See, he has proved what I said. Thank you, Sharath, really.
Thank you.
Okay.
And there used to be another engineer who wanted to ask, and then Aravindan and Abhirami also. Anything you would like to know, please ask. And I'm sorry, I'm not. I think the doctor has just come in. No, like Doctor, what is?
Doctor, what?
Dr.
No, there's the doctor from Tirupati who Dr. Kora, I think. Yes. Do you want to ask anything, sir?
Ma'am, I'll go.
Go ahead, Abhirami.
Thank you so much, Sharath. It was very insightful.
Thank you.
Your sharing. Actually, we have been doing for the past 2 years community work. Like we got an opportunity to learn community health learning program from Sochara in Bangalore. So we
Okay.
were being involved in. So I was doing a women wellness program where we spread women health awareness once a month and talk about how well-being of women, mental health is important and all. So today it was like quite inspiring for me to start this palliative work. So whenever we go inside the community, we see people like old age people or people in the palliative who needs palliative care. So it was just this in all your presentation is quite inspiring. Like it's pushing me to start this work inside the community. So involve the women in the community and start it in a small way and see how it can be taken further.
Yeah. Also, as I mentioned, so we are from an organization called DoctorNet India, making healthcare accessible to the disadvantaged people. So 10 from our organization have attended this program in the last 5 days. And today afternoon, we had a meeting and all of us were very happy and glad that we got the opportunity to attend this, because so much of work that what we do that we have learned experientially how to talk to patients and all that, when it is put in a structure like this, and then it gives us a reassurance that what we are doing is in the right path. And also there were some gaps that we were not doing, and that we were able to note it. And thank you. And one suggestion I had is like as palliative care or any these kind of healthcare work is all about collaboration. So maybe today we may not have time. So there is a WhatsApp group where all the attendees are present. Currently it is admin only. So if you can retain the WhatsApp group for one more week and then make it like not admin only, so that people in the group, all the attendees can interact one another, and then wherever there is an opportunity to collaborate among the attendees, can discuss in the WhatsApp group, and then after 1 week maybe you can close this thing. Because for example, I was talking to Matthew. I didn't know Prakash Matthew before, and I talked to him yesterday, and we were exchanging some. And also we had an opportunity to talk to Dr. Radha yesterday. So like that, there may be a lot of opportunities for collaboration. So just, I hope you will take this. Yeah. Thank you very much.
We would like others also, we would like to know about a small intro about others also, if possible.
Thank you, ma'am and sir, for that comment. Actually, that group will not be dispersed. It will be there forever. And the settings will be changed to not to like that all can send messages. Like it was made admin only just because we never wanted anyone to miss any messages coming out in that group. For this
that is perfectly understood.
So it will be useful for all of you. It will not be dispersed. It will be there.
Thank you.
Thank you.
Thank you. Thank you so much.
As I always say, see, in this group, how many of you are there? So many new friends all of you have got. Every group I tell this, okay? This is a golden opportunity for all of you, like for doctors, nurses, volunteers. God's grace, Pallium, I don't know how to thank. Okay. God brought me into their family. So I've been involved with all levels of their training programs. So one thing first I say, 50 people, 50 new friends. Okay. You're all getting this without any effort.
Yeah.
So please utilize that.
Ma'am, can I just go with one question?
Yes, go
there?
ahead, go ahead, go ahead.
I think Chakrathar Sanagavat, sorry, I don't, if I misspelled the name, just forgive, okay. So I have a question like,
Correct.
why did
Yes,
others,
I had to say, please go ahead.
why did other states didn't replicate this model? Is a lack of government policy, societal or cultural attitudes, awareness, etc. I would say that we are just telling more about the Kerala model. Okay, we speak about Kerala model, but when you consider the northern part of Kerala and this part, I would say more work is happening in the northern part, like in Malappuram, Kozhikode, Kannur, Kasaragod. So that in that area, palliative care is as much as simple as neighborhood network and palliative care. Simply because they are contributing more than us, because they don't have Pallium India, they have their own settings. Like if a person needs help, that will be arranged from the neighborhood only. So for here, we need Pallium India. So if you ask me, everything is happening or everything is good in Kerala, I would say we are also growing. So that's how you need to take initiative. Every one of you have to take initiative, and you have to think like, okay, if a small state in India, Kerala, can do that, so why can't we? So that's kind of a thing we have to just make. And in maybe, I don't know, after 5 or 6 years, it will be like there will be no word like Kerala model of palliative care. There will be Indian model of palliative care. Who knows?
Very good. No, that is Dr. M.R. Rajagopal's dream.
Yes.
So let us all work towards it. Take this palliative care to the needy. Because still I know so many places, even morphine is not available for someone who is suffering with cancer, and because oral morphine is so cheapest, okay, that is not available, and they are struggling in pain still. Why should they do that? Why can't they get it? We have developed in leaps and bounds. Everyone has phone. Who doesn't have? Everyone has smartphone also, not even normal phone. Okay, phones are 10,000 rupees. This is 5 rupees, like that it is. Whereas that we are not able to get and provide. So it's something, it's a slowly only we will go, like baby steps will get us all there. But like there were some more things in the chat. Sinia, to add Hema Chandar's number to the group. Okay. And then just couple of things. As I told you in the beginning, I wanted, if anybody else wants to say something, please go ahead. If not, I will say the 2 things which I wanted to tell.
Okay. I am a Malayali. So can I visit your center
Warm
when
welcome.
I am in Kerala?
It's not only open for Malayalis, it's open
No.
for
I said no. I said Malayali because the language will not be a barrier. That is why I mentioned Malayali.
No, we have got one doctor from Jammu Kashmir who is trying and talking Malayalam now, you know. So we have people from everywhere.
Okay. Thank you.
Everyone welcome. I've been telling Sharath from day one, come see to believe.
Yeah, thank you.
You have a connect with some Bangalore palliative care so that I can do a volunteering, home-based volunteering.
Sharath, Sinia, you have the list, of all these
Yes. I will share the list of our facilitation team. So we do have 5 state facilitation coordinators with us. So they will be redirecting you to the palliative care centers. I will share the contact details in the WhatsApp group.
In the WhatsApp group. Okay.
They are regional
so-
coordinators.
oh,
So
that's
you
what-
can get connected.
Go ahead,
with
Senior.
them. Have the list of the palliative care centers around India.
Okay.
That's all. So list of coordinators will also be given. And then you will have also list of, there are some 50 places where you can go have hands-on. See, she's sharing one by one.
So 50 places across India?
Yes.
Okay.
So you have to find out which is close by.
I think
So
all this is
basically,
everything is available in Pallimedia website. I will share the details in the chat and notes.
So I
that
think
you can access.
Aravindan sir, just posted one like Paramedia's link, so you can just go through that. And Senior just forwarded it. So you can just copy it.
Hello.
Yes, sir.
yes, go ahead, please.
Good evening to all of you, sir. The
Yeah.
main difference between palliative care and hospice care.
Yes, sir. Can you repeat that, please?
I know
The
the
difference between palliative care and hospice care. What is the
Yeah.
difference between
What is the
them?
difference between palliative care and hospice care?
Yes.
Okay. So what do you think? What is hospice care? No, I'm just asking simply, what is hospice care? Because we have gone through that process in at least in the starting sessions. Like, what is hospice care? Simply. Can anyone say that?
I did.
What is hospice?
Hospice is end of life care. When the treatment, there is no cure, and death is very near.
Death is very near.
Yeah. So
I feel physical, emotional, social, psychological comfort given.
Okay. So hospice care and palliative care, these
Yes.
are interconnected also, but I would say we don't have to focus on the death. Okay. Because we focus on death more in hospice care. Here, we focus on the quality of life, then improving the quality of life, improving the quality of death, simply. So that's the biggest difference. We are not focusing on like if they're going to die, die, then we'll be like, okay, oh, they are going to die, so we don't have. We
Dying
can't.
well. Dying well, the book.
Yes. Yes. Thank you, ma'am. So if they are going to die, so we'll be like, okay, oh, they are going to die, and we don't have anything to do. But in palliative care, we usually say, if they are going to die, they will die with dignity. That's what we are mainly focusing. These two are interconnected, but a bit different. Both approaches are a bit different. We have multidisciplinary care, like meso care, the
Micro care, meso care,
meso,
everything.
and macro care. So the macro care comes under our thing, like palliative care properly. And also that if you just go to a hospice setting, so it will be a huge thing that's done by some professionals, but not in a way what palliative care does. So there's a slight difference. Yes,
I will just add on. Simple.
Yes.
Like hospice is subset. All of
Yes.
us have studied maths. Okay. You have a big circle and you will have a smaller circle inside. Okay. Because as Sharath said, on day one, there was a big graph representation, palliative care, curative care. So because I don't want to take time, because even the second day when I did my session, I did show palliative care starts along at the time of diagnosis. So palliative care, any life-threatening or life-limiting. So not only life-threatening. See, threatening means death is imminent. Life-limiting means quality of life is reduced. So any such illness can come. This is definition of palliative care. I or Sharath, we are not newly forming. Okay. So anyone who needs long-term care because his quality of life is not as a normal person will come under palliative care. Whereas hospice care is literally end of life care. So this is a subset, like in a big A intersection B, that the other direction, how all of you will have children and you would have all taught. So which is inside the big circle. That is hospice. Hospice is end of life care, but palliative care is the whole process. Is that clear, sir?
Yes.
Maybe.
Can I add one more thing?
Yes, yes, please.
Whenever we say about
Can I
palliative,
illustrate with some examples, madam?
yes, sir. I'll just
Dementia. Yes, go ahead, sir.
simply. In the start of the session, also we told you like, okay, how palliative care works. It starts with the diagnosis. In hospice care, it means if you have 6 months to live, then they will start the hospice care. So whenever there is a diagnosis comes, we will start the palliative care. So it doesn't affect your day-to-day life. So it will improve your quality of life, and you can get. You're not feeling that I'm going to die. Okay, I'm just having this kind of problem. So these are the things could be done. So that's the basic thing. And if you have an illness that is causing you death by 6 months, like you are in the final 6 months of life, then they will be taken it by hospice. That is the thing. And anytime, that means when you just came through, like if the diagnosis is diagnosed now, you can get palliative care, no problem. So we can provide it, no problem at all. Then
I will give, we can give to you, go ahead, and then I will also add on a couple of examples so that it's clear.
Sorry, Sharath. Actually, my husband was diagnosed with stage 4 esophageal cancer.
Okay.
But since the beginning, he was under palliative care. And though his quantity of life was not extended, he had a quality life. So
You would have had chemo radiation also.
Chemo radiation, yeah. He was under chemo radiation. Surgery was not provided, but he was under chemo radiation, the combination of the two, and even on immunotherapy for some time. But I think he had a dignified, he was not in pain, or all that aspects were taken care of. So I feel palliative care was, it's not as if person is going to die. That is why that's not what I feel. But because we spent the last 8 months in a very happy way, the interaction or whatever, it was quite natural, though it was painful. Of course, I do understand for me as well as him, but then it was not as if, okay, he's going to die. It's not today. Or I don't know. I'm not, maybe right now it's overwhelming, so I'm not able to explain.
No, don't worry. So thank you for telling. I am going to give 2 examples. Sorry, Sharath, for see, dementia patient you take. Okay, dementia patient. Nutshell, I won't take long. 2 to 3 minutes. I'll give 2 examples. For example, dementia, when it's diagnosed, just for Mr. Damodaran's understanding.
Yes.
For example, dementia, any neurological problem from diagnosis to deterioration can be 2 years to 4 years, 6 years, something like that. So initially they may be all right. So there itself palliative care can begin. First 2 years they may be fine, okay? But suddenly first 2 years they may be all right. But 3rd year, 4th year, they will decline. They won't recognize anyone. They will walk away. So do something and all, more harm to themselves. So from what they were okay to slowly deteriorating.
Okay.
Okay. And then they may get to a stage where they don't know themselves. They need full-time support and care.
Okay.
So, okay, 2014, they were fine. But 2016, they are not the same. And in 2016 itself, January to December, maybe total downfall. Okay. And then 2016, November to Jan or Feb, they are really not well. They are bed bound. And that bed bound also they may take, and then last 4 weeks, 6 weeks, something, they totally don't know anything. So that 4 to 6 weeks is hospice. Okay. And then this 2.5, 3 years. So that is one example for general debilitating illness. I'll go
Right.
for cancer also.
Okay.
Okay. If you take a malignancy, cancer, and then
Okay.
diagnosed, maybe they were stage 2. Okay, full blown treatment, chemo, radiation, surgery, everything done. 6 months. That time also you register to palliative care because chemo, radiation can have so many side effects. Everything may not be able to be tackled by the oncology team. They are 400 patients to see. Okay, whereas the palliative care team will take care of each symptomatic management.
Okay. Another clarification.
Okay. And then 1 minute, let me finish. And
Okay.
then for the same patient, after 6 months, another PET scan, you do no rest. Sometimes very good. I'll tell both. Very good response. So he survives for 3 years. 3 years later, some recurrence can. Or in 7th month, none of this helped. He has got more mets, or another new thing has cropped up somewhere. Then in 2 months, then he may need palliative radiation, palliative chemotherapy. So there more palliation. So from 5% palliation to 50% palliation. Then suddenly he may deteriorate, then he will need hospice. Okay, this is just to understand. God's grace, the clinical experience only. I have worked in Adair Cancer Institute for 3 years.
Okay.
As a palliative care physician.
Okay.
Go ahead and ask.
One more issue, madam. We are from Rotary Club Tirupati. We want to start a palliative care at with the assistance of Ruya Hospital Tirupati. Can anyone provide us a financial estimation?
See, all that. See, first and foremost, first you need training. Everything you have to contact. Sharath, those help Palliam will do.
We got
no, not only for volunteer training. You need, if you want to start a service, you need a doctor, nurse, social worker.
Yes.
You have to train all of them. All that support Palliam will give. Am I right or not, Sinia?
In Tirupati, we are there, madam, to help, sir. In Tirupati, we are there to help, sir. As a surgeon, I am ready to do.
No, are you trained? No.
What
Are
is
you
the
trained in palliative care?
Financial aspects? What are the financial aspects involved in, and how much it would be? See, we should get prepared.
You have to find out. You have to find out. See, those things, Sharath and Sinia, you have to answer these things for me.
For starting a palliative care in your place, okay. So what we do is we will be first thing will be the training sessions for the persons who are trying to start it. Then we have our own team to facilitate that with the help of a memorandum of understanding. Then we will be helping you by what are the things needed to be done, how much it will cost in your place, so how we can contribute, and what are the medications you should take, what are the things needed to be registered. So these all procedures can be helped. Okay, so we will help you. So I think we have a list of persons listed there, like regional facilitators for all the places. For the south, I think Lalit will be taking care. So you can contact Lalit and ask him. So he will guide you through properly.
What is contact number?
Actually, it's in the chat box.
There in the chat box. Basically, thank you, Sharath. As Sharath has said, see, in the chat box, you have someone called as Lalit. Yes, last name. He is the south, under south his name comes. Okay. Next thing, no, as thank you, Sharath. As Sharath mentioned, there is enough information. They will tell you cost, what indent, everything they've got for 5 patients, 10 patients. So like that, you will have to get in touch with. Yes, everything is there. They will handhold. They will tell you. That's why I'm telling. No, it will start. It will, as they've all showed you. It will. This is a demo model. They will tell you who has to be trained. How from step 1, like from cost, manpower, training, like that. Every element they will help, and then they will be with you until you start the setup. Like Lalit will do that.
And after starting your setting also, we will be guiding you every month or whatever help you need. So we will be visiting for like making corrections If the thing is going properly, we will check it, because we do have some policies, like we want to make sure everything is going on the proper way.
Smoothly.
Yes.
Okay. Now,
So
because
you
we
have
are-
training programs for the doctors as well, in case the team of doctors that want to attend. Okay.
Yes.
Okay.
Yes.
Yes.
We need to train the
Sir,
minimum
Yes,
one
yes.
doctor,
Madam-
nurse, and
Bharati Madam is taking, Bharati Madam, who was a previous superintendent of the hospital, she is now undergoing this one training in our campaign.
Sir, actually, I
Madam.
have got trained by myself, but to start the center, actually, I am in touch with Lalit.
Okay.
Okay.
Lalit
great.
only has put this our program into come across, and he has given some part of finance need for the manpower everything, and for infrastructure he is doing his exercise. I have contacted Lalit sir. From him only I got the information.
Okay.
Bharati Madam is guiding us very nicely. We are following Bharati Madam guidance only. That's why we are entered into this good platform. Thank you, Bharati Ma'am.
Okay.
Okay.
Thank you, Madam Radha Madam.
Most
Thank you.
welcome. Most
Thank you.
welcome.
Thank you.
Thank you
Thank
so
you.
much, madam.
See,
Thank you so much.
end of the day, all of you should work towards welfare of everyone. So the two things what I wanted to tell all of you was, there is a movie called Secret. Okay. All of you can see, be good, do good. Like, see, it is just goodness. Be good, do good, spread good. So that is the motto of it. Okay. That was one thing. And then next, about learning, anything you learn has 4 components. There is a Subhashitam, or a Sanskrit verse, so which says Acharya Padamadate. That means when you go to school and study, you will get only 1/4. Okay. Next, Shishya Swamedaya. All of you have to put some effort and try. Like when you study, you go to library and read, no? Why? To get more information. Okay. Then next is Padam Sabrahmacharibhya. That is combined studies or group discussion. Okay. Then fourth, 25%, very important. Kala Kramena, by life experience. Okay. So you will get 100%. So 25, 25, 25, 25. Okay. This is golden statement for anything you do.
Okay.
Okay, this is just, I just wanted to share because all of you are interested and doing that. So think good, do good, something good will come. But I don't say that no obstacles, easy, cool, catwalk. No. Bumps, rides, everything you will have. And if you are sticking to law, legal, as the doctor mentioned, why? I want all of you to be safe, not to be hurt. When you're doing some good effort, take care of yourself too.
Okay. Okay. Thank you.
That's it.
Thank
you for
Thank you,
patiently
ma'am.
listening to.
Thank you, ma'am. Thank you
Thank
so
you, ma'am.
much, ma'am.
Thank you.
Okay,
Thank you.
Sinia, big thank you to Sharath. Okay.
Yeah, thank you, Sharath.
For
Thank you, ma'am.
taking through everyone, because these were the queries all the time they had. I was constantly telling them, at the 5th day you will all know everything. Having done this session before, I was confident enough. So thank you, the whole team, and thank you, Sharath, once again. And Sinia, I think I'll hand over to you.
Thank you, madam. Thank you very much.
Thank you so much, ma'am, for facilitating with us for the last 5 days. Thank you all for joining here with us for the volunteer training program. So the group will be active and all the other details will be shared in the WhatsApp group with you all. Thank you all. Kindly keep in touch. Bye-bye.
Bye.
Thank you. Good luck and God's grace blessings to all.